Welcome to the deep dive. This is where we take your, stack of research, articles, notes, and really dig into them.
Yeah, we pull out the essential knowledge you need to get truly well informed on a topic.
And today, we're plunging into some pretty complex material. It explores personality disorders.
That's right. Our sources, they're an excerpt from a nursing textbook chapter and also a related PowerPoint presentation.
Yeah, it's dense stuff. But our mission here is to kind of cut through that complexity.
Right. Extract the really important insights, help you understand the core patterns, the challenges, and importantly, the care approaches.
Exactly, for personality disorders. So let's dive in. Okay, so let's unpack this. What exactly is a personality disorder? I mean, the sources start with this personality itself, right?
Yeah, basically it's defined as those, unique ways we think, feel, and behave. It's what makes us, well, us.
And personality traits, then, those are the specific characteristics, like being shy or outgoing.
Exactly, things we bring to relationships. And the key point the material makes is that usually these traits are flexible. We adapt, we learn.
We cope with stress in, like, mature ways.
Right. We use more mature defenses. But a personality disorder, that's where the pattern becomes really rigid, deeply ingrained.
And it deviates significantly from what's, like, sort of expected in a culture.
Precisely. The sources describe PDs as these enduring patterns of inner experience and behavior. They're inflexible, often unpredictable.
And they involve what the sources call primitive or immature coping strategies.
Yeah, ways of dealing with things that ultimately cause problems. You see these maladaptive patterns in thinking, feeling, how people relate to others.
And impulse control.
And impulse control, yeah, leading to real distress or impairment. In relationships, work, school, lots of areas.
And here's a crucial point, and maybe a frustrating one, from the sources. People with PDs often don't realize their own traits are the issue.
That's a huge point. They might genuinely blame other people or, external circumstances for the problems they're experiencing. That lack of insight is key.
Okay, so that lack of insight leads into the scope, maybe?
Yeah.
Because this stuff gets really interesting when you look at how common they are.
Oh, absolutely.
Yeah.
The sources cite data, I think it was from 2017,
Yeah.
suggesting about 9.1% of the population had any personality disorder in the past year.
Wow. Nearly 1 in 10.
It's significant. And for borderline personality disorder, BPD specifically, the prevalence was around 1.4%.
Okay. And the source material mentions something interesting, that sex and race weren't associated with those rates. In that particular data set, anyway.
Yeah, that's what this data indicated. But what's maybe even more striking, or really crucial for understanding this, is the comorbidity.
How often they happen alongside other conditions.
Exactly. The sources state that a staggering 84.5% of people with a PD also had at least one other mental health disorder.
84.5%, that's
Yeah.
huge.
It is. And BPD had the highest rates of these co-occurring conditions.
So what kind of conditions are we talking about?
The usual suspects, often. Things like substance use disorders, eating disorders, PTSD, depression, anxiety, even other PDs sometimes, or general medical conditions.
That massive overlap. It really tells you these things rarely exist in a vacuum, doesn't it? Must make diagnosis and treatment way more complex.
Way more complex, absolutely. And the source points out that this complexity, plus that lack of insight we mentioned,
Yeah.
it means many people don't actually seek help for the personality disorder itself. Not until there's a crisis.
Like related to the depression or the substance use, maybe?
Often, yeah. Or some major life stressor hits. They just don't see their core personality patterns as the underlying issue.
Okay, so we know what they are, how common they are, this huge overlap. Now let's get into the why. How do these patterns develop? The sources are clear. There's no single simple answer.
No, definitely not. It's a mix. The material points first to genetic factors.
Right. Twin studies suggest there's a genetic vulnerability.
Yes. The sources mention strong evidence, particularly for antisocial PD, and moderate evidence for obsessive-compulsive PD.
And there was something about a link between cluster A disorders like paranoid or schizoid and schizophrenia.
But potential genetic link, yeah. It's complex, but genetics seem to play a part.
Okay, so genetics. Then building on that, they talk about neurobiological factors.
Right. Differences in certain brain areas, maybe, linked to things like emotional regulation, impulse control.
And that could be influenced by genetics or early trauma or even things like birth injuries.
Potentially, yeah. The sources specifically mention dysregulation in brain circuits involving serotonin and GABA,
Okay.
which are tied to things like irritability, impulsivity, hypersensitivity patterns you see a lot in BPD. Lower serotonin is also linked to antisocial PD in the sources.
And they mention actual structural differences, like in brain scans.
Yeah, some observed differences for BPD and antisocial PD, especially in areas involved in emotion processing, decision-making,
Mm.
like the hippocampus, amygdala, frontal lobes.
Okay, shifting gears a bit. Psychological theory. The sources put a lot of emphasis on childhood trauma and adverse experiences here.
A huge emphasis, particularly for BPD and antisocial PD.
So for BPD, what kind of experiences are we talking about?
Things like physical or sexual abuse, the sources note that as most common but also early separation from caregivers, emotional or physical neglect.
Parental insensitivity, creating invalidating experiences.
Exactly, that feeling like your emotions are wrong or dismissed or just too much, that invalidation seems key.
And for antisocial PD, what does the history look like there, according to the sources?
Often a history of really harsh or erratic discipline, maybe inadequate supervision, parental substance abuse, or criminal behavior.
And again, child abuse is noted as a common factor there, too.
Very common, yeah. The picture that often emerges is one of really difficult, unstable, sometimes dangerous early environments.
Right. And finally, the material just touches on cultural considerations.
Briefly, yeah. Basically saying that while PDs seem to exist everywhere, research on how they might look different across various ethnic or racial groups, well, the findings are inconsistent or conflicting.
So jury's still out on the specifics of cultural expression, it sounds like.
Okay, so given these complex origins, these deep patterns, how do people with PDs tend to cope? The sources talk about using more primitive strategies, defense mechanisms.
That often shift blame outward.
Yeah, displacing responsibility. One key mechanism they describe is splitting.
Splitting, sometimes called black and white thinking.
Exactly. It's this inability to hold two opposing thoughts or feelings at the same time. So people, situations, they're either all good or all bad.
There are gray areas, no nuance.
None. The sources say this is seen most often in borderline personality disorder, and you can see how it would make relationships incredibly rocky.
Yeah, constantly flipping between seeing someone as perfect, then suddenly they're terrible.
Total idealization followed by complete devaluation. Very destabilizing.
Okay, splitting. What else?
The other one mentioned is projection identification. This one's a bit more subtle.
How does that work?
It's like you unconsciously believe someone else has an untrue negative opinion about you. The example given is, my boss hates me, even if there's zero evidence.
Okay.
But then maybe because you believe it, you start acting in ways, maybe defensively or suspiciously, that actually makes your boss start to dislike you.
Ah, so your belief, even if initially false, actually makes itself come true through your own actions, a self-fulfilling prophecy.
Kind of, yeah. And you're often totally unaware you're doing it. The sources say this is seen most often in paranoid PDs, but can happen with others too.
So both splitting and projection identification. They push responsibility away and make it hard to learn from things.
Definitely. They protect the person from difficult feelings in the short term, maybe, but cause big problems long term.
Right. So to help make sense of all these different patterns, the source material groups them into 3 clusters, A, B, and C.
Yeah, based on shared features. It's a helpful way to categorize them for study and sometimes clinically.
So cluster A. This is the odd or eccentric group.
These individuals might show behaviors that, on the surface can sometimes look a bit like aspects of schizophrenia, but they are distinct conditions.
And this includes paranoid PD, schizoid PD, and schizotypal PD.
Correct. The common thread here is often patterns of distrust or social detachment or just peculiar ways of thinking and relating.
Okay, let's break those down. Paranoid PD. The name kind of says it. Intense suspicion.
Pervasive suspicion and distrust, yeah. They're always looking for hidden meanings, hold grudges, struggle to forgive perceived slights.
Can seem hostile or sarcastic.
Yeah, generate conflict. The source uses vignettes, like Miss Sands, thinking people are reading her mind, or Mr. Cole getting angry and suspicious of a nurse for no reason. The core struggle is seeing the world as threatening.
Okay. Then schizoid PD. This is different, right? More about detachment.
Profound detachment. An inability to form relationships, plus a really restricted range of emotional expression. These are people who genuinely prefer solitude.
Find little pleasure in social stuff. Indifferent to praise or criticism.
Pretty much. They might pursue solitary hobbies, seem emotionally flat. The Mr. Ortiz vignette in the source isolated, avoiding connection really captures that. Their struggle isn't fear, it's more a lack of desire for connection.
Got it. And the third one in cluster A is schizotypal PD. Still odd, but different again.
Yeah, here you see not just the social difficulties, but also cognitive and perceptual distortions. unusual beliefs, odd thinking or speech, strange perceptual experiences.
Like magical thinking or ideas of reference.
Exactly. They lack close friends, often described as eccentric. The presentation even used pop culture examples like Willy Wonka or Shrek from the source material itself to illustrate this oddness.
Interesting. So their core struggle is that discomfort with others plus these unusual thought patterns.
Right, that combination.
Okay, that's cluster A. Moving on to cluster B, this is the dramatic, emotional, or erratic group.
Yes. The common theme here is intensity. Intense emotional expression, behaviors that can seem flamboyant, erratic, maybe self-focused, high emotional reactivity.
And this one includes antisocial PD, borderline PD, histrionic PD, and narcissistic PD. These often seem like the most visible in terms of conflict and drama.
You can be, yeah. Let's start with antisocial PD. This is characterized by a persistent disregard for and violation of the rights of others.
And a real lack of remorse.
A striking lack of remorse, yeah. So sources describe people who might be superficially charming, but underneath are manipulative, deceitful, impulsive, irresponsible.
Often getting into criminal behavior.
Frequently. The DSM-5 criteria mentioned highlight things like failing to conform to laws, deceitfulness, impulsivity, aggressiveness, recklessness, irresponsibility, and that lack of remorse.
Sounds like they get bored easily, take risks.
Yes, trying to feel alive. They account for a high proportion of arrests, more common in males, according to the source. The Mr. Jones vignette, extorting someone, is a pretty stark example. The core struggle is that fundamental disregard for rules and others.
Okay, next up, borderline PD, BPD. The sources spend a lot of time on this one. Instability is the key word.
Instability across the board. Intense, unstable relationships swinging between idealizing someone and devaluing them.
It's splitting again.
That's splitting in action.
Yeah.
Also an unstable sense of self. Really significant mood swings, marked impulsivity.
And a huge fear of abandonment.
A frantic fear, yeah.
Yeah.
Real or imagined, it drives a lot of the behavior. They feel emotions incredibly intensely and struggle massively to regulate them.
So you see things like inappropriate anger, self-harm, suicidal gestures.
Impulsive actions like risky spending or sex, substance use, potential paranoia or dissociation under stress. The Mrs. Kit vignette, terrified of abandonment, self-harming, that illustrates it well. The core struggle is just overwhelming emotional pain and desperate, often destructive attempts to manage it.
Wow. Okay. Then histrionic PD. What's the pattern here?
Excessive emotionality and a pervasive need to be the center of attention. They use self-dramatization, maybe flamboyance, to get that attention.
Speech can be vague, lots of drama, but not much detail.
Exactly. Impressionistic. Rapid emotional shifts, but often shallow. Relationships often don't last because of that constant need for attention. The Mrs. Miller vignette, flirting, dramatic stories is the source's example. The core struggle is that intense need for external validation.
And the last one in cluster B, in narcissistic PD.
Right. This involves that grandiose sense of self-importance, preoccupation with fantasies of success, power, brilliance, a belief that they're special.
Need excessive admiration, lack empathy, exploit others.
Check, check, check. Often arrogant, entitled. But crucially, the sources note their self-esteem is actually quite fragile underneath.
So they react badly to criticism, blame others.
Very much so. Can lead to depression or difficulties when that facade is threatened. The Mr. Chad vignette, demanding admiration, feeling superior, illustrates it. The core struggle is this deep insecurity masked by grandiosity.
Okay, clusters A and B down. Last one, cluster C, characterized by anxiety or fearfulness.
Yeah, the common thread here is significant anxiety, social inhibition, feelings of inadequacy, and often a strong need for control or support, rooted in fear.
And this includes avoidant PD, dependent PD, and obsessive-compulsive PD.
That's right.
So avoidant PD, high anxiety, fear of criticism.
Intense fear of criticism or rejection, yeah. Leads to pervasive feelings of inadequacy. They want close relationships deep down, but actively avoid social situations because they're so afraid of being judged or rejected.
So they end up pretty isolated.
Often in self-imposed isolation, yeah. See themselves as socially inept, inferior. The source notes almost all also have social phobia. Keith, the programmer avoiding interaction, is the example. The core struggle is that intense fear of negative evaluation blocking connection.
Then dependent PD. This is more about needing to be taken care of.
An excessive need, driven by a core fear they can't survive alone. They end up being submissive, clingy, needing others to make major life decisions.
Difficulty initiating things themselves. Lack of confidence.
Big time. They might even tolerate abusive situations just to avoid being alone. If a relationship ends, there's an urgent need to find a replacement. The Mike vignette, relying heavily on his wife and doctor, shows this. The core struggle is that profound lack of self-reliance and fear of abandonment.
And finally, obsessive-compulsive PD, OCPD, which the source stresses is not the same as OCD.
Very important distinction. OCPD is a personality pattern. It's about this preoccupation with orderliness, control, perfectionism. But it comes at the expense of flexibility, efficiency, even relationships.
Rigid rules, focused on details, difficulty adapting.
Extremely. Their perfectionism can actually interfere with getting tasks done. They're reluctant to delegate. Their self-worth is often tied solely to work or productivity, excluding fun or friendships.
Formal demeanor, maybe rigid about morals or ethics. Financially stingy.
All mentioned in the source, yeah. They get distressed in situations they can't control. The core struggle is this overwhelming need for control and perfection that stifles flexibility and connection.
And the sources also quickly mention passive-aggressive traits. Not a formal diagnosis now, but...
Right. Just described as this tendency towards indirect hostility. Stubbornness, maybe deliberate inefficiency, subtly undermining others' plans. Mr. Martin, using his mother to sabotage things, is the example given.
Okay, wow. That's a complex landscape of disorders. Understanding them is one thing, but how do healthcare professionals, the sources focus on nurses, actually provide care? It sounds incredibly challenging.
It absolutely can be. The sources frame the approach using the nursing process. Starts with assessment.
And safety is number one.
Always. Priority 1 is assessing any risk of self-harm, suicide, or harm to others. Then, ruling out medical causes or other psychiatric disorders, identifying those comorbid conditions we talked about.
And considering the cultural context, right, that seemed important.
Crucial. Viewing the behavior within the person's background, and also very important, the need for caregivers to be aware of their own emotional reactions.
Countertransference. Because these patients can evoke strong feelings.
Very strong feelings. Negative ones sometimes. Being aware of that is vital for objective care.
Okay, assessment. Then planning and implementation, what does that involve?
Creating a structured approach is key. The sources talk about educating staff, encouraging patients to link their feelings to their actions, being really present and responsive to validate them.
And communication within the care team seems vital, especially about those countertransference feelings.
Absolutely. Discussing those reactions helps ensure consistent, therapeutic care, not reactive care.
And the goals, short-term versus long-term.
Short-term is often crisis stabilization. Safety, engagement, managing acute symptoms. Long-term goals are broader. Reducing destructive behaviors, minimizing manipulation, linking actions to consequences, building functional alternatives, managing emotions better, creating a lifestyle that prevents regression.
Makes sense. So what about specific interventions, like for manipulative behavior?
The core principle there is clear, calm, consistent limits. Discussing your reactions with peers before labeling behavior is important.
So don't just jump to manipulative.
Right. Assess first. Then set limits calmly, non-punitively. Be consistent. That means the whole team. Document objectively. Clear boundaries, clear consequences, and enforcing them.
And things to avoid.
Definitely avoid discussing yourself or other staff, promising secrets, accepting gifts, doing special favors, anything that blurs those professional boundaries.
Okay. And for impulsive behavior?
Strategies there involve helping the patient identify triggers, what thoughts, what feelings come before the impulsive act, helping them see the pattern.
And explore the consequences.
Yeah, the effects on themselves and others to build motivation for change. Then, once they can recognize the cues, you discuss alternatives. Teach coping skills, anger management, assertiveness training, stuff like that.
Got it. And communication itself sounds like a core intervention.
Foundational. Therapeutic communication involves limit setting, trustworthiness, managing manipulation attempts effectively, and just being authentic.
General principles like building trust, being respectful, punctual, doing what you say you'll do.
Basic, but crucial for this population. Then the approach might be tailored a bit by cluster.
So for cluster A, the autocentric group.
The sources suggest a more business-like, maybe slightly less warm approach initially, to avoid increasing suspicion. Respect their need for distance, acknowledge their concerns without debating them.
Okay. Cluster B, the dramaticerratic.
Building trust is still key, but professional boundaries need to be super clear because of the potential for manipulation or intense transference. Provide opportunities to talk about those intense feelings, especially around self-harm urges.
Consistent staff seems important there, like one or two main people.
Yes, assigning consistent staff helps. A clear, structured care plan, maybe even a behavioral contract. setting limits calmly, non-accusingly.
And cluster C, the anxious fearful.
Provide empathy for their distress. Avoid getting into power struggles. Encourage them to take responsibility, but supportively. Collaborative problem-solving works well here.
Makes sense. The sources also mention milieu therapy, using the whole environment.
Yeah, often a group setting. It provides a safe space to learn and practice social skills, coping mechanisms. Requires that consistent team approach. Mutual goal setting.
And there was that specific point about BPD and hospitalization.
Right. The source noted evidence suggests long-term hospitalization isn't effective for preventing suicide in BPD. Brief, intensive, crisis-oriented treatment plus good outpatient care seems to be a better model.
Interesting. Okay, what about psychotherapy? That seems central.
Absolutely. The sources mentioned cognitive behavioral therapy, CBT, and interpersonal therapy, IPT, show effectiveness.
But they really highlighted dialectical behavior therapy, DBT, especially for BPD.
Yes, DBT, developed by Marsha Linehan. It's considered evidence-based for BPD. It's specifically designed to target those core difficulties, the emotional dysregulation, the chaotic relationships, the self-destructive behaviors.
And it involves individual and group therapy, focused on specific skills.
Exactly. 4 core skill modules: mindfulness, being present, interpersonal effectiveness, managing relationships, distress tolerance, getting through crises without making things worse, and emotional regulation, understanding and managing intense emotions.
Okay, what about medications? Can they treat the PD itself?
The sources are clear. No FDA-approved meds specifically for the personality disorders themselves.
Ah, okay, so what are they used for?
They're used to treat the associated symptoms and those common co-occurring conditions. So SSRIs might be used for depression or anxiety. Mood stabilizers like carbamazepine or lamotrigine was noted as beneficial for BPD, can help with mood instability.
Any others mention?
Clomipramine for OCPD symptoms sometimes. Antipsychotics might be used for transient psychotic symptoms or sometimes as adjuncts for mood stability or aggression. But they really caution against using benzodiazepines because of the high risk for misuse in this population.
Right. And finally, a really important point the sources make: caregiver self-care.
Absolutely crucial. Because, as we said, working with individuals with PDs can be incredibly emotionally demanding. It can trigger strong reactions in staff that counter-transference again.
So caregivers need support too.
Definitely. Actively managing their own stress, acknowledging their emotional responses, getting regular supervision, having supportive colleagues. It's all presented as vital. Vital for the caregiver's well-being and vital for providing good, consistent care.
Okay, let's try to bring some of this together. The source material includes a vignette about Maria, diagnosed with borderline personality disorder. How does that illustrate these concepts?
Well, right away, you see those core BPD patterns. Maria gets intensely anxious when her primary nurse is leaving for a few days. That fear of abandonment is palpable.
And then the splitting kicks in.
Instantly. She idealizes the departing nurse, calls her Maria the Daisy, and immediately devalues the covering nurse, calling her fake before even really interacting. That rapid shift is classic.
And her behavior, expressing suicidal thoughts, scratching her arm, that seems directly linked to that fear of abandonment.
It does. It's presented as a maladaptive coping mechanism triggered by that intense fear. And the source walks through the nurse's response, which highlights the communication strategies.
How so?
Well, Maria says something like, "I might not be here when you get back," which is clearly manipulative, playing on the nurse's potential guilt or fear.
So how does the nurse handle it?
Calmly sets a limit, states clearly when she will return, but also validates Maria's underlying feeling, acknowledging her behavior stems from distress. I understand her behavior. So empathy, but firm boundaries, not giving in to the manipulation.
Yeah, you can see the challenge. The nurse even notes their own anxiety increasing, reinforces that need for self-awareness and self-care for the staff.
Exactly. The vignette also connects back to the evidence-based practice points. It mentions Maria's BPD diagnosis, the recommendation for DBT.
Medication for symptoms.
Right, and the need for teamwork therapists, psychiatrist, nurse, all collaborating.
And it touches on those self-help strategies too.
Yeah, things Maria could potentially learn and use, like distress tolerance skills the source mentions, splashing cold water, snapping a rubber band, keeping a mood diary to spot triggers, creating a safety plan. Practical things highlighted in the material.
Okay, so pulling it all together, what does this all mean? Where does this deep dive leave us?
Well, I think the main takeaway is that personality disorders are deeply ingrained patterns. They affect thinking, feeling, behaving, and they stem from this really complex mix: genetics, neurobiology, and often, especially for some types, difficult or traumatic early life experiences seem really significant according to these sources.
And they really impact a person's life. Relationships, functioning,
Yeah.
often involving those primitive coping mechanisms like splitting, and frequently that lack of insight.
Right, which makes seeking and engaging in help difficult. Caring for individuals with PDs, as the sources show, requires really informed, patient-skilled approaches.
Safety first, always. But
Mhm.
also those consistent boundaries, building trust, using evidence-based therapies like DBT where appropriate.
And addressing the comorbidities.
Yeah.
You can't ignore the depression or substance use that often goes along with it.
And critically, supporting the care team themselves. That point about countertransference and burnout risk seemed really important.
Absolutely essential for sustainable, effective care.
So, given everything we've unpacked, especially that significant role the source material gives to early adverse experiences in developing conditions like BPD and antisocial PD, here's something to maybe reflect on.
Yeah.
How might a greater focus, maybe societal, maybe clinical, on identifying and really supporting children and families who are facing that kind of early adversity, how might that potentially impact the future prevalence or the outcomes of these challenging personality patterns down the road?
That's a really big question, but definitely one these sources implicitly raise, isn't it? Something to think about.